So we'll be going to the part 2, and part 3 will be regarding the what is the new development in the arrhythmia treatment. So in this part, we will be touching the approach to arrhythmia cases, which is very fundamental for everybody. Excuse. Come forward. So, bedside evaluation of arrhythmia. So, in this, I will briefly discuss how we. Okay, so bedside evaluation of arrhythmia. Arrhythmia include both tachy and bradyarrhythmias. So we are going to touch upon the three important aspects. What is the basic regarding the arrhythmias, decision taking and drug device, and EP study, how to decide the cases. The, if you can say there are four important complaints. The most important complaint of any arrhythmia is the palpitation, for which everybody is knowing. But there are two important findings. One is the fainting, syncope, or loss of consciousness. This is also presentation of arrhythmia. Sudden cardiac death is in the domain of electrophysiology, and this is most of the time not been discussed in more detail. Dizziness, paroxysmal sweating. So this complaint, sometimes patient will be saying that all of a sudden a lot of sweating has happened and weakness, and after that for half an hour I was feeling somewhat dizzy also, but later on I recovered. I was having no complaints. So dizziness is spelled with sweating. Whenever sweating is happening, means some autonomic abnormality is happening. And if palpitation or weakness, palpitation when the person is able to feel the heartbeat, but when the if the heartbeat is very fast, the blood pressure drops, and the patient will be having a feeling of fatigability or weakness. So weakness, which is coming paroxysmal, should be taken as a finding of uh, arrhythmia, mostly tachyarrhythmia or maybe bradyarrhythmias. Some patient, means patient who is older, maybe around 60s, diabetes, hypertension, they will not be complaining palpitation. They say chest pain on and off, sometimes comes and go, because they may be having coronary issue or microvascular angina develop at the same time when the palpitation happening. Pain is taking over the palpitation, so they will complain pain. We have seen a patient who is having means WPW syndrome. Whenever the palpitation will be coming, means heart rate is going 170, 180, he will be giving more pain than palpitation. क्या हो रहा है? दर्द हो रहा है. But he is not having the, he's having normal angio, but palpitation was manifesting as a microvascular angina. Okay. So all five presentation in which the palpitation is the most common. Regarding the syncope, syncope is one of the diagnoses which we should know that it has to be drilled in a very what do you call it, detective way. We should not give a inform okay syncope. If in ER coming, where the patient goes first, the patient goes for the MRI, which is not the usual way. You have to detect the patient, take a history, what he was doing, when he has done, any complaints preceding to that one, post how the respiration, all those informations are vital. Then we have to see the background check, diabetic, hypertensive, risk factor, any similar episode has happened or not. That's why you have to keep in the mind how you are doing, what he was doing, who was seen. All those questions in and around the event you have to ask like a detective. Then only syncope story stops. Otherwise, you do 10 investigation and later on you will be in the doubt. Seizure versus syncope, I will not go much in detail because this is a total clinical discussion not related to the ECG. And whenever syncope is happening in a particular scenario, means dehydration or neuromed, means the person is having any psychological stress in that, if he is means happening, then it is a we can say that is a vaguely mediated. In that scenario, the history is enough to make the conclusions. But patient can have the cardiomyopathy, or he may be having channelopathies, coronary anomalies, left ventricular hypertrophy, scar, arrhythmias. These may be presenting with a syncope also. And this is important. Why it is important for clinical parlance? Because what your brain doesn't know, I will not be able to detect it. So you should be knowing what you are dealing with. Maybe a ECG is normal, but the scenario is fitting in one of the clinical syndrome of arrhythmia, which we have to keep a suspicion and investigate also. So basic investigation start with the ECG and echo. These two information will give two important things: how the ECG when the patient is not having syncope, number one; whether it is giving any smoke, means firing has happened, means WPW delta waves, T wave inversions, or you are getting a bundle branch block, or you are getting a PR prolongation, or you are getting a short run of VPCs. So these are indirectly the smokes on which you have to see what has fired before the event. So you have to start making the what are the possibilities. Echo is one of the important investigation in any cardiology. This one, it gives the structural how the heart is, whether any structural abnormality of valve or muscle is there or not, means function is good or not, valves are functioning or not. All valve is having a different type of permutation combination of some symptoms. Like patient is having aortic stenosis, will be having syncope, so very common to identify. So you have done the echo over, the patient may be having cardiac arrest or maybe having VT, or changes. So that become this. And if heart is totally normal, then our story start. Okay, now next what? So it is a muscle disease or there or not, subtle muscle disease or there or not, right ventricular ARVD is there or not. Like that, all those conclusions you have to make, and accordingly you have to start putting your knowledge on the particular ECG and started ECG, Holter, EP test, all those things, cardiac MRI, PET CT, all this will start setting one by one. But first is ECG echo. This will give what can be the further diagnosis, possible diagnosis. So basic, what is the bradyarrhythmia, tachyarrhythmia? So tachyarrhythmia is coming first. So when the heart rate is going high, what are the things we have to see? So first question we have to answer whether it is a he or she. So there is no third gender I am using here. So either you have to use male or female, and male and female is whether the QRS is wide and narrow. So whenever you are uh, calling any consultant, ask the first question to yourself: narrow QRS or wide QRS? Without that, there is no need of giving information. Sir, tachycardia is there, VT hai ki nahi? So if you are saying is a wide QRS, tachycardia rate is 180, patient is unstable, we are knowing that is until proved otherwise a VT. Patient is stable, wide QRS, still VT is possible, but yes, hemodynamically stable VT or SVT with abrasion, both possibility will be coming. Patient is having echo, you have done, you have seen the echo is having LV dysfunction. So it is more in the favor of VT. Like that, permutation combination will be coming. So narrow versus wide, and that definition we have already gone. It is something called, in arrhythmia, it is he and she, means you have to know the gender, what you are dealing it, and accordingly you have to take a call. This concept I have already, anything which is above the node, it will be narrow. If it is coming below, then only it will be wide, or if it is above also, it can become widened if the bundle branch are having diseases. Concept of broad QRS, why QRS get broader? So one is the common sequential activation of ventricle, means the ventricle, left and right ventricle are getting activated simultaneously. That's why the QRS are narrow. When right or left are taking precedence over the other, right bundle is slowed, so left is conducting normal, so left ventricle is contracting, or you can say left electrification has happened, and then right, so QRS is getting wider. So this is called sequential activation of ventricles. So bundle branch, either RBB, LBB, or ventricles is giving, muscles is giving the rhythm, because muscles are slowly conducting systems, so it will not be wider. And third, if conduction is happening through the accessory pathway, we call as bundle of Kent, all those things. The reason is, again, it is the muscular conduction. It is not the bundle branch or Purkinje fiber, because these are the fastest conducting system in the human body, the speed is very fast, so it will be always narrow. When it is going through the muscles, it will be wider. So one bundle branch block, second is ventricular tachycardia, and third is accessory pathway. Or conduction is having the HPM. His Purkinje system is diseased. So ischemia affecting the system, or you have given some drug like class 1C drugs. Class 1C, propafenone, morisizin. These drugs, when you are giving, the QRS will become wider over the time. And electrolyte imbalances. So whenever broadening is happening, always check those things like hyperkalemia. You will be getting a broadening of QRS. So either the disease is there or there is some intermittent cause, ischemia, drug, or electrolyte imbalances. Then it will happen. Coming to the narrow QRS, bit easier. Patient is mostly stable. And the first question we have to ask when you are saying narrow, what next question you have to ask from yourself. So whether you are getting regular versus irregular. When you are saying regular, the DDs are very fixed. These are the total 3-4 diagnoses. If it is irregular, again you are having some fixed diagnosis. So if the patient is having regularity is not there, QRS is narrow QRS, tachycardia is there, atrial fibrillation is the first possibility. You are not going to get a P wave, or you are not getting a fixed P wave, either of the things. You get some P wave here and there. All the P wave morphologies are changing, and you are not sometimes getting P wave also. Then it is atrial fibrillation. There is one more important diagnosis is called atrial MAT, multifocal atrial tear. The P wave morphology is totally changing. So every P wave is different, and the rate will be more than 100. The differentiation of atrial fibrillation versus MAT is both are having some indulation of P wave, but here you are getting a different P wave. Every P wave is different, and it will happen in a particular background. A patient who is healthy, he will not be having MAT anytime. You have to see the background. So background is he is having a very metabolic abnormality, means electrolyte imbalances, infection, all ongoing, or he may be having a respiratory issues. Patient is having COPD, and later on UTI has happened, AKI happened. So this type of scenario, you are going to expect a MAT. Mostly of pulmonary diseases, terminal pulmonary diseases will be having the MAT. If a patient of COPD or emphysema is coming, it is taken as a death sentence. Means after that, the recovery chances will be a bit less. Now the ventilator are there, you can keep for long time, they are different. But when we are not having ventilator, that time it was almost like a death. These are the terminal rhythm event MAT. Patient will start throwing MAT. And sometimes the multifocal atrial, these are the two diagnoses. Means P waves you are getting different, or P wave you are not getting. And the QRS will be always irregular. So MAT versus atrial fibrillation. AFib treatment will be very fixed. Number one, anticoagulant. Number two, rate control in the acute. If hemodynamically unstable, shocked. Simple. Now coming to the regular. So in regular, what we are going to look for? Whether you are getting P wave or not. Okay. So first thing, if you are able to see the P wave, where you are going to expect the P wave? P wave will be inside the QRS. P wave will be prior to QRS. P wave will be after the QRS. These are three possibilities. So if you are getting, there is no P wave, means there is a P wave inside the QRS. Why I am saying it? Why? Why nam pucho, you will not be able to understand. When you are using the word narrow, means it is above the node. When above the node it is happening, means atrium is going to be contracting, or you can say depolarization, and depolarization of ventricle is happening. But ventricular and atrial depolarization is happening simultaneously. What will happen? It will go inside. No? So it is almost like a parallel activation of both the system, atrium and ventricle. That's why P will be inside the QRS. Think about that depolarization of the atrium is happening just after QRS. So what will happen? It will be falling just after the QRS. So it will be bleep-like thing. We can say R wave or Q wave, depending upon what is the terminal wave. If it is happening very slow, means very later on, it will fall far ahead, far after the QRS. So if it is happening after the QRS, after a long distance, you are able to see the P wave. Then you can say, okay, this is a P wave. It is inverted versus positive. That is a story different. But P wave is there. Means atrial activation, ventricular activation, and something above the node. These three information are there vital to make your conclusions. Is it clear? So P wave is there, P and QRS is there, and P is falling out of the QRS means it is a totally a rhythm in which the activation of atrial and ventricle both are going. Possibility of re-entry tachycardia will be there. And then we use the word what you call here. Sorry, here we are going to see two possibilities: short RP and long RP. Short RP means R to P. If you are able to see, and it is less than half of the RR interval, means it is before the midway. Okay, so it is a short RP. If it is crossing the half of the RR wave, means it is taken as a long RP. And the importance of long RP, short RP, what we use as electrophysiologists is that you are away from node versus near to the node. If the node is if the origin of the tachycardia is near to node, it will be either inside the QRS or just after the QRS. It is far from the node, it will be taking more time to reach it. Okay, so focal atrial tachycardia will be having long RP tachycardia. Atrial tachycardia will be mostly having the long RP tachycardia. The reason is it is away from the AV node. It will be right atrial, left atrial. But if it is falling towards the node, means the focus of tachycardia is near to the node, you will not get the P wave first of all. If at all you are getting a P wave, it will be very narrow because both the atrium is activating, or it will be merged inside the QRS. So it will be behaving more like a AV and RT because node is the area of interest. Okay, that will discuss later. So long RP, short RP is less than 70. If you are able to see, you can stem the diagnosis AV and RT. If it is more than 70, we are having three possibility, and for that we have to put the patient in the EP, and there are some diagnostic there. But if you are using the long RP diagnosis, there are three important diagnoses. Number one, atrial tachycardia. Number two, atrial means right atrial, left atrial, anywhere. Second is PJRT, paroxysmal junctional reentrant tachycardia, and atypical AVNRT. So this is a for the EP point of atypical versus typical. I don't want to confuse, but one of the variant of AVNRT. So P more than QRS. Sorry, yeah. So if the patient is having regular tachycardia, give adenosine and just see what is happening. No change. What are the possibility? You have not given the proper dose. That is one possibility. Or consider it may be a VT because sometimes there are some VT where the QRS will be narrow if it is coming from the septum. But for time being, just think about you have not given properly. If the patient is having sinus tachycardia, what will happen? The rate will reduce and later on it will normalize it. Okay, so gradual slowing followed by again acceleration. So sinus tachycardia, focal tachycardia, non-junctional tachycardia, non-paroxysmal junction tachycardia. So it can originate from the SA node, it can originate from atrium, it can originate from AV node. So all these three are having a behavior that when you are giving adenosine, and if it is automatic, means mostly they are automatic, means all the time firing. So when you are given adenosine, it is suppressed, again started beating. So what will happen? Atrial tachycardia will not terminate. It will go, it will slow and later on go on. Even atrial flutter is also there, it will also go. It will be running, means rate will reduce, later on it will be running. Because we are blocking what? AV node. So AV node block for 6 seconds, later on again tachycardia is going on. So this is the way we identify it. And if it is suddenly break, means all of a sudden straight line आया उसके बाद देख लो PQRS 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 आ रहा है. So this is happening in the patient is having AVRT AVNRT. Some of the focal atrial tachycardia which is originating near the AV node that will also behave like the same, like a AVNRT. And finally, if P waves are persisting without any change in the P waves, then it is a flutter. Okay. So you have given adenosine. What is happening here? Given adenosine, this what you are seeing here, rhythm is going on. What is the rhythm is? Atrial tachycardia. If the if there is no straight line, it will be called a flutter. Okay, since straight line is there between the two wave, we are seeing a atrial tachycardia. And never be hurry to give any adenosine in this type. Irregular, number one, irregular broad QRS tachycardia. The time you give adenosine, the patient will go in VF. And if you are not having shocking machine, the patient may die also. So broad QRS never. This is this you can see here broad it is here. Here it is becoming narrow. So broad narrow is going on and it is irregular. Usually it is pre-excited atrial fibrillation. Means patient is having WPW syndrome. On top he is developing AF also. So this ECG will never give adenosine. Never give cardron also. Cardron will block the AV node because of beta blocker action. Don't give beta blocker, calcium channel blocker, adenosine. All three are contraindicated. Okay, it is a legal issue. I am saying that's why. In that scenario, if you have shock, better shock it. If you have to give one medicine, that is ibutylite. Ibutylite is going to block the pathway first, then the AV node. So that time the conduction will not happen and the patient will. Okay. Dopitylite, ibutylite, these are the two drugs we give cardron. Most of the time nothing happens, but sometimes patient may develop VF also. So pre-excited AF, you should not give it. I will complete AV node because I think everybody is looking exhausted. Okay, so AV nodal dependent versus independent means whether AV node is the part of the circuit or not. So there are two tachycardia where the P wave will be more than QRS, and atrial flutter and atrial tachycardia. These are two rhythms in which we have to think about that they are not dependent on AV node. They are going here means in the atrium, and they will be having a AV nodal dependent tachycardia. So node is the part of the circuit. So one is AV nodal re-entrant tachycardia and second is AVRT, atrioventricular re-entrant tachycardia. So there the time you give adenosine, they will interrupt AVNRT, AVRT. So in the ECG also you can see the after when you are terminating, after that you have to see there is a delta waves are there. So you can think about the patient is having WPW syndrome, and that was, and then the diagnosis will be AVRT, not AVNRT. Pathway means AVRT. Without pathway, AVNRT. So during narrow QRS take what are the things we have to do? Number one, if you are able to see the P waves. Second, more P before each QRS, segment between P wave. What is the things? If the more P is there and segment between two P wave are horizontal, it is a atrial tachycardia. If there is no straight line between two wave, it is a atrial flutter. So P wave location on the ST segment is a long RP versus short RP. The diagnosis will be there. And appearance of pseudo R wave in V1 or S wave in inferior lead. If you are getting any time P waves, here we are seeing the P wave. P wave is there. More P wave versus QRS, then you are having flutter versus atrial tachycardia. Now one P wave followed by long RP versus short RP. Long RP we are having atrial tachycardia as a first possibility, or PGRT. There are two possibilities. If P wave is there but it is short RP and it is falling at the QRS, just after the QRS, then it will behave like a pseudo R wave in V1 and pseudo S wave in lead 2. So in that scenario, you have to put up a diagnosis of AV and RT because QRS and P are simultaneously. How it is possible? Both are activated at the same time. This is called parallel activation of the and ST deviation. So just briefly, I will cover this one. So RP, this I have already told how it is will be there. Further the this what you call circuit from the AV node, longer the RP will be. Okay. So you can see here, able to see what is happening. The last visco. Short RP में the P wave is just after the QRS. Sometime you may not be able to see this one also. P wave you are not able to understand because you are seeing all the time positive P waves before the QRS. But sometime when you are not getting, you can see the first ECG here. This is up. Sorry, you are able to see this one. Let me make it broader. Short RP, long RP. What I was using. This is the same. Here, any P wave you are getting anywhere? If you are not getting P wave, where are the P wave locations? Three locations. Number one location before you are not getting any P wave before. There is possibility it can be under QRS and it can be after. If it is after QRS, what are the locations? So this is the location here. It is ST depression type thing, you know. So it is inverted P wave. This is inverted 2-3 AVF. It is inverted P wave. So when we are taking a line like this, when it inverted P wave, that's why the whatever the ST depression when you are seeing, these are reflection of the inverted P wave in that particular lead. As a means when we see the ECG, we go give this thing. And this is the pseudo R wave, what I was saying initially. So here you are getting small P wave just after the QRS. You're seeing same thing. It is means you can by seeing you can say this is the case of AV and RT. AV and RT. The reason is you are getting a clear cut P wave which is splintered to QRS. When it is AVRT, the QRS will the P wave will not be splintered to QRS. Are you getting this point? When the pathway is there, means you are having AV nodal system and you are having pathway. This is called AVRT. In this, it has to go like this one and it has come to like this one. So there is a serial activation of atrial and ventricle. So there is always a time gap between the atrial and ventricle activation. When we are saying AV and RT, it is the node inside the whole things is going on. So here also going, there also going. So P will be either in the QRS or it will be just after QRS and splintered. And that's why when the short RP, if you are getting R to P less than 70 until proved otherwise, it is AV and RT. By seeing this, no need of going to do the EP study. You can directly label it. So that is the importance that if you are able to, and the same morphology you are getting small r here or a small s wave here, it will the same what you call AV and RT. Our intervention guys, whenever this, you will also give a call, sir, the patient is having ST depression. So when the tachycardia is ongoing, these ST depression are the mark of inverted P waves. And by seeing this ECG, I can say the patient is having left lateral pathway because this is V1 to V4 to V6 ST depression is happening. This is happening on the lateral side of the heart, means the P wave is activating from this side. The left atrium is getting activated first, and that's why it is giving a impression of inverted P wave in that side. So this is ST depression and this is AV and RT, AVRT, sorry. Okay. So ST depression is for us, for as electrophysiologists, we make a diagnosis of AVRT. And after termination, what you are going to look for? You are going to see the short PR is there or not, delta wave is there or not, and what are the location of delta wave. So here we can see, and we can say the patient is in a left lateral pathway, and the reason is type A. Positive, na V1. Lead V1 is positive. Delta wave is positive means type A WPW syndrome. So this is a WPW syndrome. You can see, not able to see. This is short PR and this is a positive. So you are not expecting V1 to be positive. V1 is positive means activation is happening from the left side. Harshvardhan is not happy, huh? So when RBB happening, what is happening? Right bundle left is activating first. So RSR pattern is when the same thing here, the same rule is that when the pathway is on the left side, what will happen? Left will be activating first, it will be taking over. So anything which is there, it is opposite, it will be happening. So there, that's why it will be positive here. We are not expecting a positive here. Activation is happening on the left side of the heart to the right side of the heart. And it will be broader. Okay, so right bundle branch block pattern is equivalent to left heart pre-excitation. Is it clear? So upright P waves, inferior lead. You can see. Are you able to see here? Here you can get a clear cut P wave here. P wave is there or not? Are you getting or not? P wave? P wave? So when you are getting it heart rate at around 170, 180 and P wave are positive, what are the diagnoses? AVRT, AVNRT, atrial tachycardia, what is? Hmm? So easy diagnosis. It is atrial tachycardia. And how? PSVT, only three diagnoses you should remember, right? Forget about all things. If regular tachycardia, AVRT, AVNRT, and atrial tachycardia. These are the three things you have to differentiate. AVRT, AVNRT, I have told just now. If you are getting a splintered P wave, short RP, chances of AVNRT will be higher, or that will be possible. If you are getting a long RP, still the AVNRT can be possible, but you have to, then we have to bring the patient in the cath lab and EP diagnostic maneuvers we have to do to make the diagnosis. But if you are getting clear cut P wave which is upright in inferior lead, means activation is happening like this one. AVRT, AVNRT, what is happening? Up to down. So inferior lead will be always negative P waves in the inferior leads. So when the inferior lead you are getting either ST depressions or T wave inverted. P wave inverted. It is down to up. So it is AVRT, AVNRT. If it is up to down, atrial tachycardia. Any atrial tachycardia which is coming from up to, is it clear? So see the P wave in the inferior lead and you are saying positive, okay, there is no possibility, it is atrial tachycardia. You give 10 times adenosine, the patient will be still in the tachycardia. Okay? Don't waste your time. If at all you want, put on the cardron. You want to reduce the rate, give calcium channel blocker, beta blocker to reduce the rate. Okay? Don't repeatedly give 12 milligram, 24 milligram. They are not going to be successful. So where to concentrate? Inferior lead. 2, 3 positive, don't waste time. It is atrial tachycardia. It will not respond to adenosine. P wave more than QRS. Acha, ये तो I think I will not go in detail in this one. This one pregnant lady, which she came in 8th month, 7th month, and whatever medicine we are giving, it was not responding. The heart rate was, you can see how much the heart rate is around 170, 180, second pregnancy. Finally, one time we thought we will go for the ablation also, but before ablation, I thought cardron we can't give. Cardron is a contraindicated drug. So we have started on flecainamide. And on that, the heart rate reduced to 120, 130 later on. After some time, in the third day, the patient's tachycardia terminated. And later on, after pregnancy, she was fine. Not a single time it has come. So we have not to do the ablation also. So it was coming from the pulmonary foci. So these tachycardia will be very fast, means pulmonary vein atrial tachycardia will be having this type of behavior. Usually, sometime it precipitated during the pregnancy, and they will be very resistant to any drugs. And pregnancy, you are handcuffed with our choices. If he is coming in this one, what you call post pregnancy, give a cardron, you can chase any tachycardia with a cardron, amidron, what you can say. But during pregnancy, you are having very selected choices. And this concept, just now I did, when the straight line between P wave, for the norms, we say that it's atrial tachycardia. If you are not getting a P wave in between the two P waves, then it is a flutter. So this is an ECG diagnosis. As an electrophysiologist, we don't accept this thing. We have to, when we bring in the cath lab, it is focal versus general. It is a micro reentrant versus macro reentrant. Micro reentrant means the tachycardia circuit is very small. Then we say it is a focal lateral tachycardia, FAT. If it is a macro reentrant tachycardia, then we use the word atrial flutter. So they will be having CTI dependent, typical flutter, atypical flutter, mitral annulus flutter, pulmonary vein flutter in and around. Like that, different locus. There's some locus which are very tuned to develop the flutter. Means it is a macro reentrant tachycardia, and that's why flutter versus fibrillation, the You may get sometime P waves in the flutter also. Flutter you will be always getting. Fibrillation also you will be getting some P waves. The differentiation is only one. If you are getting similar, same P wave morphology,